Hello and welcome to this series of interviews and panel discussions that we are doing called the COVID-19 Navigating the Second Wave. This is a series that Newslaundry will be doing over the next few weeks, where we are going to put forward your questions to experts who can answer them. Right now, in the state we are in, especially I live in Delhi, the situation is very dire. There is a lot of information doing the rounds, and there's a lot of misinformation also doing the round. And there's a lot of also half information doing the round. So we need to sort of, during this time, inform ourselves better on how to deal with this virus. The idea of this series is also to understand what the virus is, because as you must have seen, there are mutations coming in. There are a lot of complicated things also happening with the virus and how people are dealing with it, and strategies are changing constantly between governments and people as well. So we are going to touch upon that, but some housekeeping announcements before I begin. So if you are here, you're a subscriber, hello and welcome. You can ask your questions directly to Dr. Rao here. And if you are watching this on YouTube, please leave questions in the comments below, so that we can collate them and ask them to the next expert that comes in, and we can put forward the questions according to their expertise as well. This will be a series of sessions we'll be doing, so we will try our best to take your questions forward to experts. And we are also crowdsourcing questions on email and also on social media. So feel free to tag Newslaundry and put forward your questions. We will take those as well. So to begin with, let me introduce our guest. We have Dr. Jammi Rao with us. Dr. Rao is an independent health physician and an epidemiologist, and he has over 25 years of work experience in Britain's National Health Service. And he is also, you're also a visiting professor, right, in Staffordshire University. So welcome, Dr. Rao.
Thank you very much.
To begin with, is there anything that you would like to say to our audiences?
No, nothing much. Just by way of introduction, it is a pretty tough situation out in India and in many parts of the world as well. All sorts of questions. So we need to work together on this. Is all I can say for now.
So today's session, we are going to focus on testing mostly. We are going to go theme by theme. There will be more sessions on different themes, but right now we are going to also focus a little bit more on testing. Of course, there will be general questions coming in as well, and Dr. Rao will take those as well. But the initial part of this session will be about testing. So I have a bunch of questions of my own as well, and there are some questions which I have crowdsourced as well. To begin with, can we start with just the very basic questions? What are the kinds of tests available to us right now to detect this virus?
Okay, to give a broad overview, there are two broad kinds of tests. One is the test that tells you whether somebody is carrying the virus in their throat and in their upper respiratory tract. The other one is the test that tells you whether someone has had the infection in the past sometimes. So the first one looks for the virus or for remnants of the virus in the throat. And the best known one, of course, everyone knows about it by now, it's become part of the sort of common natural language almost now, is the RT-PCR test, where you are actually looking for the viral RNA, for the virus's RNA. So you take a swab, send it off to the lab, they do something called reverse transcriptase and polymerase chain reaction. That is the RT-PCR. And what that means is that they're converting the RNA into DNA, and then they are multiplying it so that it's almost like magnifying it. One single molecule of DNA nobody can detect, but once you magnify it and grow it and it becomes more and more and more, then you can pick it up. And if you pick it up, it means that the RNA came from the throat of the sample that you took. That's the first test. There are other tests that have come up. That's the famous rapid antigen test,
yes,
which has taken over testing because it is quicker to do. You get the result faster. But there are drawbacks. Anything in life, everything has got sort of, you gain something here and you lose something elsewhere. And one of the drawbacks, of course, is that it might give you a false negative result. So even if the person has got it, it might give you a false negative test. But there again, that depends upon the situation in which you're doing it and how well it is done. And there are loads of kits that are available for the rapid antigen test. In fact, in one recent Cochrane review, they looked at something like 35 or more studies were looked at. They looked, I've got it here in front of me now. They looked at a large number of studies. They looked at 78 study cohorts. Including with that, and for at least 29 different kits were used, and there are WHO standards for these tests. So the key thing is for the government or the regulatory authority in each country to establish and standardize on these tests and make sure that companies just can't introduce whatever test they want, because otherwise you won't know how reliable a particular test is.
So from what I understand, so the RT-PCR test, of course, everyone knows about it, and it takes, I think, how long does it take for the results to come usually? Like if it's like the perfect process, so how long should that take?
It would take around 2 days.
Around 2 days. Okay.
1 to 2 days before you get the result. And I understand now, because of laboratory overload and problems with sort of logistics and so on, it's taking up to 4 or 5 days to sort of get the test.
Actually, it's very strange though, because I was also under the impression that I would get it in 2 days, but when I got my test done, it came the very next day. So I was also like a little wary about what that means. Is that okay for that to happen?
I think depends upon individual laboratories, and also the speed with which it is grown, it is replicated, the cycles that can be shorter or more depending upon the viral load. So it is also dependent on the viral load in the sample that has been collected. But all these tests have got one important drawback. One is how well the sample has been collected, how well it's been transported, and a certain amount of laboratory quality control, if you like.
So if we talk about that with like an individual, keeping an individual in mind, so whenever testing happens for someone, what sort of things they need to care about? When the tester comes to them, what is it that they need to look out for?
When the tester comes, all they need to do is to be ready for someone to put a throat swab into their throat first and into their nose. That can be an slightly unpleasant experience, especially if somebody else is doing it for you. Increasingly, in some parts of the world, the kit is sent out and you do it yourself and send it back. Now, those have got a drawback. You may not do it as well as somebody else doing it to you. So you may get a slightly inadequate sample on the swab, and therefore you run a small risk of getting a false negative test. But the one important thing to say about testing is that we often get very worried about doing a test and getting the result back and then acting on it. But it depends upon the context in which you're doing the test. If you are asymptomatic and part of a study, then it's okay. You can wait 3 or 4 days or whatever time it takes. It doesn't matter. But in the middle of an epidemic, particularly in the middle of a second wave of the epidemic, the need for a test may well be less clinical and more epidemiological. That sounds complicated. Let me explain that. From a clinical point of view, the need for the test may not be as great, because whether you do the test and you're waiting for the result, or the test is positive when it comes back 3 or 4 days later or whatever, your best bet is to act as if you've got the infection if you have symptoms.
Okay.
And not worry about the test result. Waiting for the test result is not an excuse to pretend you're safe and you don't have it in the middle of an epidemic. So you can make what's called a presumptive diagnosis of COVID-19 in the middle of an epidemic. If you have fever, if you have a new onset cough, if you have other symptoms of body ache, and sometimes diarrhea, loss of taste, loss of smell, and if you have tiredness and weakness and lethargy, then assume you've got COVID.
Right. Even if the test results come negative?
Even before the test result comes, you can act as that. It may come back negative. Even if it comes back negative, it makes sense to continue to act as if you've got COVID.
Okay. So essentially, look at your symptoms and don't really depend on tests when you have those symptoms, just to be safe. Yeah. Fair. So a connected question would be, when should a person go for testing? Essentially, is it that they should wait for symptoms, or they can do like regular checks?
Regular checks would overload the system in India, in the Indian context at the present time. I wouldn't advocate that in the middle of an epidemic. Now, for example, what's happening in England now is people are being encouraged to do 2 tests a week.
Okay.
It's free. You can send off for the kit and you can send off your 2 tests a week sample and do it properly. That is because they want to monitor the prevalence and the incidence of asymptomatic infection. As Britain is opening up, they're asking people to do more and more tests to catch the earliest sign of a third wave.
Right.
But that's a luxury that Britain can now afford to do. In the Indian context, it would overload the system if people did that.
Right.
People should act as if there is as if the people around them have got the infection. They should take all sensible precautions and pretend and act as if there is infection around them, rather than depending on testing. Testing can lead to a false sense of security. Even if you test negative, it doesn't mean that you can't not wear a mask. You still have to wear a mask, you still have to socially distance, and you still have to be careful of crowds and crowded places.
Right. So I want to come back to the antigen versus RT-PCR as well. Should we trust antigen? Like a plain question.
Yeah, I think you can. Yes, by and large, most rapid antigen tests, especially those which meet the WHO standards and which have been quality controlled and quality approved, are quite reliable. They may be more reliable in people who are symptomatic than in people who are asymptomatic. So if you have symptoms and you go to a hospital or a clinic and they do the rapid antigen test and that comes back negative, there is a small likelihood that it is a false negative test. But if it comes back positive, you can be quite certain that you do have COVID.
So as far as I know, antigen tests work because you have antibodies inside you after you get the virus. Is that how that works?
Not at all. No. The antigen test is simply they call it the antigen test because they are using the fact that the protein inside your throat, the protein coming from the virus, is reacted antigenically with an antibody, which they have prepared in advance, and that tells you whether you have the antigen or not. So the antigen test is quite similar to the RT-PCR test in the sense that it is detecting the presence of the virus in your throat at the time the sample is taken.
All right.
As opposed to the antibody test, in which they take a blood sample and look for antibodies in your blood, which means you had the infection sometime in the past.
Right. There are a few more questions that people have been asking regarding testing also. Even today, there was this statement that was given by the AIMS director saying that CT scans are being recommended, right, to detect pneumonia in the lungs. And that is also despite testing. So, and he said that do not go for that. What would you say to that? When a doctor recommends CT scans, what does that mean?
That's absolutely correct. What the AIMS director said is absolutely spot on correct. I have been for some time now arguing that CT scans are unnecessary for the vast majority of patients who've got COVID, either when they first have symptoms or when they are in hospital. CT scans do not by themselves determine either the diagnosis or the treatment.
Okay.
Nor do they tell you anything useful about what your long-term consequences can be. All that the CT scan does is it picks up the fact that you've got pneumonia, you've got inflammation of the lungs. Now, it doesn't matter whether you have it or not in terms of treatment, because even if you have the pneumonia, it doesn't mean that you need intensive care. That depends upon how you are reacting to it, how affected you are by it. It doesn't mean that you need oxygen, because that depends upon how breathless you are. So it doesn't do anything of clinical value to the patient.
Right. So it's not a COVID detection test is what you're saying?
No, it is definitely not a COVID detection test. It's non-specific. It tells you that you've got pneumonia. In the case of, in the presence of a positive RT-PCR test, you can conclude that the pneumonia you have is a COVID pneumonia.
Right. And is it treated differently though? Like the COVID pneumonia versus like a regular pneumonia, if you want to call it, is it like anything different there?
Not at all, except for one small fact. If you have what is old-fashioned regular pneumonia, which is caused by the pneumococcal bacterium, you would be given antibiotics broad spectrum. You'd be given penicillin or some such antibiotic, and you would recover fairly rapidly. In the case of COVID, the treatment is completely and entirely supportive and symptomatic. Symptomatic meaning you take paracetamol for fever or something for the cough if you are quite troubled by the cough, oxygen if you are breathless, intensive care if you can't breathe for yourself. These are all supportive treatments while your body is getting better.
Right.
So the treatment is no different for both the pneumonias, except in this one regard, that you might give antibiotics for a bacterial pneumonia and nothing specific for a viral pneumonia.
Okay. So we have a few questions already. So Rashmi Mahajan is asking, how do we make sure that rapid antigen tests we are taking are of good quality? And are there any things that we should keep in mind?
I find that's a difficult question to answer from the point of view of the individual citizen. I think it is hard for individual lay people to decide whether the test they are getting is of a high enough, it has been quality assured or not. That is the responsibility of the regulatory process and the regulatory institutions. So they need to check all the kits that are being produced and give some kind of quality mark for each product and do it. And that's one of the big differences, that if you have a good regulatory system, you can rely on what is being offered by the hospital and the clinics with a reasonable degree of certainty and trust. So trust is the important thing in this whole business, really. People need to have the trust that somebody somewhere has done his job, done the quality control for these various kits that are coming out, and has given you the guarantee that it works. Don't worry about it. You don't have to worry about it. But I can't see how even I, as an informed non-expert in the biochemistry of testing, would be able to determine whether the test is reliable or not. I simply could not. I have to depend upon the certificate of quality given to it by the regulatory agencies.
Right. So it's like a quality assurance thing that needs to be done for tests as well.
Exactly.
And I mean, of course, like that's a very, I mean, the regulators have to figure it out. And I'm not entirely sure, but the Delhi government and I think the Maharashtra government had given out notifications saying that these are the places where you can get tested from.
I see.
Was that was that like a certificate given to them ki they do good quality tests therefore, or are they just available?
I don't know the answer to that. I hope it is the former. I hope they have been through a quality control process. Quality control is not. Yeah.
Actually, that's something that I'll also have to look into. This is very
look into that.
I haven't really thought about this before as well.
And the quality control, by the way, can't be a one-off. It has to be a continuous process.
Yes, of course, like a periodic quality control.
Exactly.
There is one more question from an anonymous attendee. British variant won't be detected by RT-PCR tests, ? Are there any specific symptoms for this variant, the British variant? So, but I want to make this a little larger. Do actual mutations make the test results vary, or do the tests have to be changed to detect particular mutations, or is it like the broad brush test in general?
The test is the same for all mutants. If you do the RT-PCR test, you pick up the fact that there is viral RNA inside you. Now, genome sequencing will determine whether it is the original coronavirus virus protein, or whether it's a variant that's come in. And for that, you must have genome sequencing. And India does have about 10 laboratories run by INSACOG. Ashoka University's what's his name? The professor in Ashoka University. He's part of the group that does the testing, and they have got a program of testing a certain number of samples. I believe they have now reached almost 1% of all samples being genome sequenced, so they know what the prevalence of different mutant variations are.
Right. So genome sequencing is the next step, essentially.
Is the next step, and that is not necessary for the patient or for you and me to get involved in. That is done purely for the sake of the monitoring of the whole virus process epidemiologically, to understand whether it's changed, if it's changed, it's getting more frequent or not, and if it's getting more frequent, in which way is it moving. So if they do it properly, they can map the virus progress from different parts of the country to the rest of the country.
I have a connected question out of just pure curiosity as well. So there is this thing I was reading about, say, the double mutant variation in India, and now there is something about triple mutant as well, etc. I mean, I guess they did it after genome sequencing in India, etc.
Sequencing, yeah.
So I just want to know, do the symptoms vary according to mutations? And is it that, so for instance, because earlier they were saying that COVID spreads through the surface, like droplets on the surface, etc. Now WHO has given out today only, has accepted that it is airborne, right? So
Airborne.
did that happen because of the mutation, like the virulence increased, or like the symptoms changed, it became more deadly? Does that happen?
What we can say about the mutant strains and the variants is that the newer variants, particularly the Southeast England Kent variant and the Indian variant, are both more highly transmissible. They are more transmissible from one person to the other than the previous version of it. But it is not the case that they spread differently. So this business about airborne has got nothing to do with the mutant. It is just that our understanding has evolved about it.
Okay.
And even on that front, it's important to make an important distinction over there. This is a vital point, really. To say that it's airborne, that does not mean that it is airborne in the same sense that, for example, nitrous oxide is airborne. So, for example, pollution in the atmosphere, pollution with sort of microparticulates, less than 10 microns per 10 micron size particulate matter, that happens in Delhi around the time when you have a smog, when you have the stubble burning and all those problems coming up. It is not airborne in that sense.
So, like dust is in the air is airborne.
In the air, yeah, exactly. It's not airborne in that sense. So, therefore, if you don't, if you're living, let us say, 1 mile from anybody else around you, if you're living in the middle of a farm and there's nobody around you for a mile, you can still get air pollution. That's airborne pollution, but you cannot get coronavirus by that means. So, it's not airborne in that sense.
When you say coronavirus is airborne, what does that mean then? Like, exactly.
Okay, what that means is that initially the view was that it is spread only by two means. One is by what's called droplet infection. So as I'm talking, if I have the virus inside me, even when I talk or sing or cough or shout, it is carried in droplets coming out of my mouth. But those droplets settle down very rapidly. So you have to be very close to me to pick up that infection. Okay, but if you are more than 6 feet away, you will not get infected, even if I'm talking or whatever, because it will sink. It will sink and fall to the ground immediately.
Right.
And therefore, you are safe. That is where the whole idea of social distancing came into being. The do gaj ki duri business came from that idea.
Right.
But now there is evidence. There's some weak evidence that it may be airborne for much longer than those distances, under certain circumstances. And those circumstances are things like a closed room, for example, traveling in a lift, for example. So if somebody was coughing in a lift and came out of the lift and you entered the lift immediately after he came out, within, say, let's say for argument's sake, 30 seconds, you might breathe in the virus because it doesn't sink that rapidly. So it's not exactly airborne in the sense that air pollution is airborne, or secondhand cigarette smoke is airborne, but it is airborne in the sense that it is not completely droplet infection.
So I will give like a weird analogy that I just thought of because what you said. So it's like, when you take a perfume bottle and you spray it in the air and then it stays for a while, but it eventually dissipates. But when you go out and someone else comes in, they can still smell it. And
you can still smell it, exactly.
Something of that sort.
Yeah, something of that sort.
So guys who are watching this, please notice what is being said, and also please take care to take precautions accordingly. There is a question by Vinay Khurana here. Me and my daughter were both having similar symptoms, and we both got tested. For her, it was positive, and mine was negative, and the results were given to us within 10 hours. Do you think that the hurriedness is in giving the results caused faulty results?
Was it an RTPCR test?
I'm guessing it is because 10 hours. Vinay, you can tell us on chat. I think it is RT-PCR.
It's RT-PCR. If it's RT-PCR, that is quite rapid. That is quite fast. I'm surprised it would come back that quickly unless the viral load was very high and it replicated quickly. And we are counting from what? From sample taking or from handing it to the lab?
So I think I'll wait
Interesting.
for
This depends.
Vinay to give
Wait
you
for him
more
to
details on that. Oh, he said yes, it was RT-PCR.
PCR, right. Okay, it does take about a day to do it in most laboratories because, mind you, when I'm talking about a day, I'm not talking from when the technician gets the sample in his hand. I'm talking of sample, you have to send it, it goes to the laboratory, it comes back 2 days later. So maybe if you're counting from giving it to the lab technician and he's sort of doing a rush job on it, processing it immediately and giving it the highest priority, yes, maybe 10 hours is possible.
But this is actually a thing that I've heard happening in a lot of places. Like someone in the household tests positive while others test negative, or some people test positive and some one person tests negative. That really doesn't make any sense. How does that make sense?
You're right. It doesn't make sense very much. There are two elements there. One is the testing reliability. That could be a factor, but I think that's the less important factor. The more important factor is that we shouldn't forget that all of us have got a variable amount of resistance to anything. Even before coronavirus, when somebody came home with a cold, for example, not everybody would get infected. Some people got infected, got the cold from that person. Some people sailed through it and didn't get a cold to that person. So there is variation in things like susceptibility to any infection, and that's bound to vary a little bit. Some people are more susceptible, some are less so, and therefore some may or may not get it. But increasingly, in the second wave, everybody is reporting now widely in India that whole families are testing positive at the same time.
Yeah.
So that's what adds credibility to the theory that this new strain, whatever it is, let's assume it is a new strain, is definitely much more highly transmissible.
And plus it's very rapid. Like like as in like last wave, I remember a few people were getting infected, but this time it's like a avalanche of people testing positive.
Yes,
So
indeed.
there's a connected question to this actually by Manu Varghese. How long does it stay airborne? Do we need to worry about neighbors testing positive, navigate air circulation away from other houses?
I don't think we have the answer to that reliably.
Right.
Um, Possibly not for longer than a few hours, but certainly more than a few minutes. Anything in between is your guess. I have not seen any reliable research that looks at it and says it is airborne for this length of time. That's partly because it's very difficult to collect the virus from air samples.
Right. So you cannot measure the decay, right? I mean, like,
You cannot do that because it's hard to collect air samples and measure it. That technology is just not there. We know that if you have a viral load inside your throat, then you can take a swab and you can grow it and do things with it. But if it's in the air, you can't collect it that easily.
That's true.
So that's the reason why we really can't. I don't think we have the answer to that question. But I don't think the answer to that question is critically important. What matters is you keep your distance from people as far as possible, as long as the virus is raging in the community. We have community spread now, and as long as that situation prevails, it makes sense to maintain as much social distance as possible. The other question is,
The other question that's what I was coming to. Should neighbors testing positive worry us, and air circulation?
yes, indeed. Now, this becomes a very interesting question. You see, when you talk about neighbors, it depends upon your social context, and this is an important point to make. In parts of the world, your neighbor would be something like half a mile away because you're living in rural America. Let us say your neighbor is half a mile away. But if you're living in a slum area in a crowded urban Indian city, then your front door is literally 2 feet from the road outside you. Okay, your neighbor is almost living cheek by jowl with you. Okay, and you might probably even hear your neighbor cough at night, and there might be a connection between the two households very easily maintained. So yes, if your neighbor has got it, he really should take steps to sort of isolate himself as much as possible. But in the most Indian context, people living in high-rise buildings, in apartment complexes, and so on, if your neighbor is behind closed doors, then you're perfectly safe. And even if his window abuts yours, if he keeps his window open, as in fact people are now advised to do, then it doesn't mean that it will waft away from his window through your window into your bedroom just because you're living in the next door flat.
Right.
I don't think it will do that.
I keep imagining, I don't know why, whenever people talk about transmission, because I'm an 80s kid, I keep thinking of these Cartoon Network shows of, puff of cloud coming out and then
Yeah,
wafting
yeah,
and then going into someone else. It's just like, it's stuck
true.
in my
Yeah.
head. But guys, that doesn't happen in real life. That's the whole point. Atul Sapre asks, when should one get tested, especially since there is an overload in the lab? I think you already answered that.
Answer that. Yeah, yeah,
Yeah. Essentially, symptomatic. When you're symptomatic, that is when,
Symptomatic.
when you should get tested. I mean, if given the Indian condition is what you pointed out as well.
Yeah. And don't forget, that is not much different from what prevailed even in a country like, say, England, right up until April, May last year. In April, May last year, the advice was, if you rang up the NHS helpline in England and said, I've got a cough and a fever, I may have COVID, the advice was, stay at home, don't bother getting tested, isolate yourself for about 2 weeks, and then you're clear to come out.
Right. The isolation period also is varied, right? What is the accepted isolation period right now?
Now the accepted period is 10 days. If you have the infection, 10 days, and 10 days after 10 days, they don't even recommend doing a repeat test to confirm that you're negative. You don't need to confirm that you're negative.
Okay.
If you've isolated yourself for 10 days, you can and your symptoms are improved.
And 10 days from when you get the result, right? Or
from when the sample was taken.
From when the sample was taken, right. There are a few more. Yuvraj asks, it has been a year since the pandemic. Why haven't we been able to come up with any type of new testing methods which are better in every way?
One would argue that the rapid antigen testing is pretty robust. I mean, it does give you the answer fairly within 20 minutes, half an hour. It gives you the answer sometimes. Anything more sophisticated would be possible, but it might well cost more. And would that be affordable? I don't know the answer to that. But I think we have reasonably good testing procedures now.
Right now, yeah.
Yeah.
Also about testing availability as well. So since you also do like a lot of data research, etc., can we talk a little bit about in India especially, what have you seen? Yeah. Where are tests concentrated more? Where aren't they available? Do you have any thing to say about that?
I don't have concrete data about it because of all the data I'm getting and I'm able to look at and analyze, they are not geographically coded. They are either at the national level, all of India, or state level. There are sometimes city level data, but nothing more refined than that. It doesn't give you a PIN code, or they don't come with a PIN code attached to it. Or certainly, I think rural India is a great big data black hole at the moment.
Right.
Nobody knows what's happening in rural India because the testing is not happening as far as I can tell. We don't know what the hospitalization effects are, and we certainly don't know what the mortality is happening there. And others have also commented upon this.
Absolutely, and it's surprising that it's been a year and still that hasn't been done.
That hasn't happened.
It's actually insane. But there are a few more questions from Pranshi. How long after one has recovered can antibodies be detected in the blood? This is in case one hasn't been able to take the test while infected, but wishes to be able to donate plasma. Okay. Plasma is one thing that we decided to talk about as well, but if you can answer the first part so that we can move on to the second part.
I think antibodies could be detected for a very long time, depending upon how sensitive your assay is. But meaningful levels of antibody, at least 6 months is my guess, but I'm not sure I can quote reliable research studies to that effect. And I don't think they have been done. I don't think serial studies have been done on people who've had COVID and recovered from it to see at what point the antibody levels wanes off. But I'd be surprised if it was longer than a year, which is why we recommend the vaccine, even to people who've had the antibody, who've had the infection.
Right. And I wanted to take the plasma question also, but with a disclaimer. So Remdesivir and plasma is something that everybody is recommending. And since we decided to have this session with Dr. Rao, I've been talking to a lot of doctors and asking them about Remdesivir and plasma. And literally all of them said that it's not effective. They said there is no study that says it is effective. And one of them actually recommended that instead of focusing your energies on amplifying Remdesivir and plasma requests, because I keep getting so many of them, they said ignore those and focus on ICU beds and oxygen. How would you react to that? And what do you think about plasma and Remdesivir?
I mean, I would agree with that view completely. Plasma is definitely has been shown in a large number of studies to be ineffective. It does not save lives. It probably, in a small way, makes some people iller. And the reason for that has been speculated about. There's no research again, but it has been speculated about. Do you know what the treatment for people who have a bleeding disorder is? If somebody comes in and is bleeding heavily, and you don't know what the cause is, you do the platelets, you do coagulation factors, you do all sorts of tests and so on. But while you're waiting for all those results, one of the best treatments is to give him plasma. Because plasma also contains a good level of clotting factors, blood clotting factors. So at the same time, we also give blood thinners. We also give heparin and anticoagulation to people who've got coronavirus, in the belief that there is a clotting problem in people who have severe lung disease. So at the same time, we are giving the same people plasma. Now, if plasma increases the coagulation and clotting inside, it's going to cause the patient to become iller and possibly even die. So there is a small suspicion that plasma, far from doing any good, might actually do a small amount of harm. Though that hasn't been quantified yet. I don't want to begin a scare of anybody who's taken plasma that he's at risk of suffering consequences. But definitely, one can confidently say, I think, that plasma does not save lives.
Right. And Remdesivir?
Remdesivir, again, study after study has shown that it does not save lives. There is a faint possibility that if given early in the course of the disease, within the first 5 days, at the most 5 or 7 days, then it may reduce the duration of illness by about 1 or 1.5 days. But there are consequences to this. The consequence of acting on this advice is that you would be admitting people, because Remdesivir is given by injection. And it is the label that comes on it says not to be used outside of a hospital. So then you will unnecessarily be admitting people just to give them Remdesivir and occupying a hospital bed, which somebody with more severe disease might need more than you. So therefore, I think Remdesivir should be discouraged as much as possible. It is of little benefit, at most 1 day of illness in people who are not going to die anyway.
Right.
But it does not save lives.
It's very strange, because I've been as I said, I've been talking to doctors, and now what I'm doing is every time like a friend of mine who is a big amplifier and influencer is giving like plasma requests, and I personally message them and say, please stop doing this. This is not effective. It is actually putting people in danger, or etc. But then they said, how do we say no? It's they're like, one person put it out, is like, my sister-in-law was like recommended plasma. How do I say no to my sister-in-law, right? And it's a very, because the doctor has recommended it. So why are doctors still recommending this as well?
That's an interesting question, isn't it? I mean, I've had this debate on Twitter as well, and they say, look, you haven't practiced in India, on an Indian ward. Patients insist on it, and then if you don't give in and the patient dies, then you'll be blamed for it. But it works. But that question works both ways. I think the only answer to this is not to leave it to individual patients and doctors to decide, but to have a high-level committee or a high-level authority laying down the law, almost, not quite in legal terms, you know what I mean, laying down the guideline on this and insisting and telling hospitals, you will be marked down if you use plasma. We want you to report on plasma usage. Use it in very limited circumstances. After you've explained to the patient, you can put barriers in the path to sort of using plasma, and say patients must sign a disclaimer and say that, yes, I'm happy for the patient to get plasma, I'll take the consequences. You must change the culture of the whole system, not just expect individual patients and doctors to act in a way that runs counter to the way everybody else is acting. That never works in practice.
Right, and also it's very strange because with Remdesivir specifically, because of all these hoarding cases, no, like it is
Cases, yeah.
also becoming this view that it is a very rare commodity which everybody would
Commodity,
need at
yeah.
some point, and we will need to pay for it, and there's a giant black market around it also.
I know.
So, guys, please be careful. I don't know how you will essentially communicate to someone who is saying we need Remdesivir, but please keep these in mind. At least inform them that, listen, doctors have recommended, experts have said that this is not very useful, so please reconsider this. I mean, at least we can maybe do that.
But here's the interesting thing. Here's the really interesting thing. Even in, I think I'm right. In the last Prime Minister's Mann Ki Baat, he interviewed Dr. Shashank Joshi, and he said that Remdesivir does not save lives.
Okay.
Okay, but within 2 days of that, within 2 or 3 days of that PM's Mann Ki Baat going out, the government decided to import Remdesivir. They were going to import 475,000 doses, 475,000 doses of Remdesivir from Gilead Sciences in America and from an Egyptian manufacturer of Remdesivir. And they were going to ask Indian companies to ramp up the sort of production of Remdesivir. So this is another major problem I have, which is that we always seem to have mixed messaging in India. There isn't one consistent message.
Exactly.
It's one thing for doctors to say Remdesivir doesn't work, but yet you have a black market, and then the government is going and buying some more. So it's almost like, say, Bitcoin. No point as a financial advisor saying, "Bhaiya, Bitcoin, don't invest in Bitcoin. It's a waste of your money." But then everybody else is doing it, so you are impelled to go and do it, isn't it? Bitcoin is rare, so it must be valuable. So that kind of logic pervades, and people are chasing after Remdesivir and making themselves ill, standing in a long line to go and get Remdesivir for their patient and for their loved one in hospital, whereas it doesn't save lives.
And they could have focused on oxygen for that matter during that time. And guys, here's the thing. So like, if you are focusing on Remdesivir or plasma, you're also not focusing on things that is actually needed. That is also one more factor, that there's a lot of time that goes into getting these resources, which are not very proven to give treatment. But at the same time, when you're working on getting oxygen and beds and ICU, that would be a much more productive use of time, because the one thing that COVID patients in distress need is oxygen. Is that right, Dr. Rao?
That's right. That's right. Under certain circumstances, oxygen is genuinely helpful.
Right. So there are a lot more questions. I'm just going to take a few more from social media as well. And Dr. Rao, we'll just take 15 minutes more of questions, and then I'll let you go. Is that fine? Yeah.
Sure.
Yeah. One big question that people have been asking is, so Wake Artisan asks on Twitter, just now a person called me and told me that he is positive. However, he is not sure which medicine to take. He is in initial stage, having dry cough and a little bit of cold.
Yeah, all such a person needs to do is simply to take to bed, get as much rest as he can, drink plenty of fluids, and treat the fever symptomatically. If the fever is really bad, take paracetamol. Nothing more than paracetamol is needed. And even that, there is no dose for it. There's an upper limit of the dose, but you don't have to take 4 tablets a day. You take it as and when you feel feverish and you feel uncomfortable, body ache, that kind of thing. And that's about all. You don't need to do anything else. You may take extra fluids as much as you can tolerate. But again, having a rule saying 2 to 3 liters per day, I think doesn't make sense, because if it's a hot climate and you don't have air conditioning, you may need more. If you are if you can afford air conditioning and you're in a nice cool environment, you may not need that much fluids. So just enough fluids, and just all you have to do then is monitor your breathing. So monitor your breathing, paracetamol, bed rest, and stay at home. That's all you really need to do. There's no specific medicine that will help you either shorten the duration of illness or prevent hospitalization or prevent the need for oxygen in the next week or two.
Right. This actually brings me to the question of hospitalization as well. So you had written last year for Newslaundry, and you had pointed out how when politicians were becoming positive, they were immediately rushed to AIMS and other hospitals, and it's still happening. Whenever they test positive, they just take them just in case. Can you also like talk a little about when is the right time to hospitalize someone? When is the right time to actually start looking for beds and ICUs and oxygen?
Yeah, I mean, let's assume you're in a perfect world. We will have to assume that. Let's assume
Of
you're in a
course, yeah.
perfect world. There is no shortage of ICU beds. There is no shortage of oxygen in the hospital. Then the best place for you is to stay at home, provided your home is reasonably decent, you have a bedroom, you can isolate, and you're reasonably comfortable. The best thing is to stay at home as long as possible. Even if you need oxygen, it is possible now to get the oxygen delivered at home. So when your oxygen saturation is, let us say, around 92, you may need to start taking oxygen. You do not need to take enough so much oxygen that you come back to normal. That's not necessary. 92, 94 is good enough, even with oxygen. And so long as you can talk in full sentences, even if you don't have one of those oximeter things, it's okay. You don't need an oximeter desperately. If you can talk full sentences, your breathing is not labored, your so-called accessory muscles of respiration, your sternomastoid is not overacting, and you're comfortable, you can afford to stay at home without an oximeter. If you have to go beyond that, in other words, you're taking oxygen, 6 to 7 liters per minute of pure oxygen and through a mask, and you're still having labored breathing and you can't talk, that is when you may need hospital admission. And the reason for hospital admission is twofold. One is to ensure that your hydration is maintained because you can't drink in that situation. And the second thing is you may be in imminent need of emergency ventilation.
Right.
Unless you need ventilation, either non-invasive or invasive, unless you need ventilation, you shouldn't be in hospital. Which is why many countries began the idea of massive, large, temporary field hospitals. Even in London, they never used it. It so happened. But in London, for example, in the first wave, they built a large field hospital with about 2,000 beds in it, simply to keep people in a place where there is no intensive care, but they can give them oxygen and monitor them closely. And if necessary, rush them to hospital with an ambulance.
Right.
That's the perfect world.
That's the perfect word. But like right now, so if I have an oximeter, it shows below 90 is when I should worry.
Below 90, if it is confidently showing below 90 and it's not an error, and I do have a suspicion of the cheaper versions of oximeters, they can be slightly dodgy in terms of how accurate they are.
I'm just going to show you one to get your opinion whether it is okay.
Okay,
Is this okay?
I don't know the brand. I don't know the brand of it or whatever. But I tell you what, people who buy an oximeter should start using it when they don't have COVID.
Yeah, I do that. Yeah, I kept it here for that. Yeah.
Yeah, and ideally your finger should be warm, and you should let it stabilize for about 5 minutes before you take a reading. So and then I wonder what the readings are in when you don't have COVID, when you're quite comfortable, you're breathing reasonably well, you can walk, let us say, 20 minutes without getting breathless. What your oxygen saturation is under those circumstances. I've seen machines. People have told me about machines which always read below 95.
Right.
So I don't know.
I mean, we can't really control that, I guess. I mean,
you can't control that. Yeah. So with any instrument in clinical medicine, there is a tendency to take the value it reads out as if it is absolutely precise value. But for different machines, there is a different range of error.
Right.
And that's one of the problems. What if it is
if you have to then rely on just physical signs, let's talk about that, right? So what are the physical signs that you need to see which would require hospitalization?
Yeah, one is your own individual level of comfort. If you are lying in bed comfortably and you're breathing room air, I mean no oxygen, you're breathing room air, and you're reasonably comfortable, you can get up, you can walk to the toilet, you can walk from room to room, and you can talk in full sentences like you and I are now, then you're obviously not in respiratory failure.
Okay, fair.
You don't need to be in hospital, you don't need oxygen. The next step is you can do these things only with oxygen. And the next step is you have difficulty doing these things even with oxygen. And that's when you need to be admitted in hospital. But this kind of graded response suggests that the system is very responsive to your needs. And if you need hospital admissions, it shouldn't take more than, let us say, at the most 45 minutes to get from your bed in your house, in your flat, to your hospital intensive care bed. But we're not in that situation now at the moment, are we? We are in a situation where even if you're in extremis, you will have difficulty finding a hospital bed.
That makes sense,
and that makes it very difficult.
Absolutely, and that's the worrying part as well, right? Where even if you detect the signs, you have waited till that signs appear. If you start looking for it from that point, then it's longer. So people are looking for it earlier, thinking that maybe we will need one. That unfortunately is the scenario right now. I'll take a few two last questions, which is there's one question from Rashmi Mahajan about masks. So last session that we did with Manisha, this question was also asked about what kind of masks should people look for. So her question is, there are different opinions on what kind of mask to use, N95, double masks, etc. What is the best amongst these?
There are two questions there. One is, more than which type of mask, the important thing is to have a mask and use it correctly. Those two questions will meet about 85-90% of the need. The final refinement is whether you have an N95 mask or not. N95 masks are actually more uncomfortable to wear.
They are.
And depending on the climate you're working in, if you're working in, once again, if it's a hot climate, if it's sunny, you have to walk outdoors for a little bit, you might take it off because it's very hot and sweaty and uncomfortable. So therefore, even an ordinary cloth mask, double layered if possible, double layered, not two masks, but a double layered cloth mask, is quite adequate for the purpose for which it is being used, which is that to prevent your anything that you are breathing out from falling on other people, and anything that they might be shedding from being inhaled by you. So for that purpose, it is by and large adequate. It meets the need, provided it is used properly. The number of times we've all seen people who are using a perfectly expensive good mask, but with the nose showing, makes it ineffective. So using any mask properly is 90% of the battle. The last 10% is about whether you worrying about whether it's N95 or not.
Right. And in case anyone is watching and doesn't know what an N95 looks like, this is what it looks like. That's the one. Yeah. So it's essentially this one, right? So, but I always found that cloth masks are actually more comfortably fitting because they have this strap which you can go all the way here so that it removes your but this one is super uncomfortable and it doesn't really fit properly. So that is one question that a lot of people have nowadays. And then what is this about surgical mask and then a cloth mask, or is that making any sense?
I'm not sure that it necessarily makes any great sense. A surgical mask is, I think a cloth mask is better personally, but I don't have any evidence for that.
Right.
Surgical masks may also be used really for short durations of time. They are disposable, so you can throw them away.
Absolutely. Yeah. And I'll just take one last question, which is from Dolly. This is about vaccination, but I wanted to ask you this. If a person gets vaccinated with Covishield and gets an RT-PCR test done after a few hours, the same day, will the RT-PCR test read the vaccine in the body as COVID positive? Or I think this will apply to Covaxin or any other vaccine.
Any other vaccine.
Yeah.
No, almost certainly not. The two are totally unrelated. The RT-PCR test looks for virus particles, for virus RNA in your throat. The vaccine is going into your arm, into the muscle in your arm, and it is putting in either a fragment of the virus in the case of the Pfizer vaccine, or in the case of Covishield, it's putting in a small bit of it, the spike protein bit of it, and nothing more. And therefore, the two are totally unrelated.
Okay. So they're not related at all. And people have been asking also about recovering and getting vaccinated as well? Or
Yes.
when
Yes.
should you get vaccinated? Should you wait till you recover to get vaccinated? Can you get vaccinated during when you have tested positive but maybe are asymptomatic? What is the best time then?
The official advice is if you have had an RT-PCR positive test, or if you have symptoms of COVID and you think you may have COVID, not to take the vaccine at that time.
Right.
So about 4 weeks is the official recommendation on the official vaccination immunization handbook in Britain. The advice is allow 4 weeks to elapse between having the illness and the vaccine. And the reason for that is purely pragmatic. It's nothing to do with science. And the pragmatic part of it is that you don't want to confuse the symptoms of the disease with any possible remote rare side effects of the vaccine. So have a gap, then you at least know what you're dealing with.
Right. Fair enough. Okay, thank you, Dr. Rao. We are out of time. Thank you so much, subscribers, for attending and answering our question. Shailesh is saying very disappointed that not a single question was answered. We did answer a lot of questions. I was looking at the question and answer tab. Guys, we have a lot of questions that my Excel sheet is filled till 26 columns right now, and I was hoping I can ask those as well. But rest assured, we are going to do more of this. We are trying to do 2 a week now. Right now, we did one with Dr. Rao. We will do one on Thursday, or wherever the next guest actually confirms. We are going to get a lot of people, guys. We are going to get epidemiologists. We are going to get policy researchers. We are going to get doctors. We are trying to get frontline healthcare workers who are actually on the field so that they can tell you how to behave in a hospital as well. We are going to get mental health experts so that they can talk to you about the effects of mental health this COVID is having on you and what you can do with it, and how you can deal with it. So there are a lot of more sessions being planned. So please don't think this is the last one. If you have one question or whatever, you can always leave them on contact@newslaundry.com. Just make sure you put in subject COVID question so that we can collate them. We are constantly keeping a track. Whenever experts come in, we are going to post those questions. So please be assured that we will try to get as many answers to you as we can during this period. Thank you so much, Dr. Rao. You have been wonderful, and thank you for doing this with us.
Thank you very much. I hope that was helpful. Thank you.